So hi guys and welcome to MedCatalist classes. So in this session we are going to discuss about one of the most important cardiology disease, that is MI. We all know across the globe, not only in India, across the world, the 30 to 40% death in a population occurring because of this disease, that is MI. So we all know what happens in this disease, nothing but narrowing of a coronary artery, which is the major blood supply to the heart. So let's discuss like what actually happens in this disease. So let's discuss couple of aspects in this session, that is like angina and an MI. So let me show you like why the chest pain occurs in the individual. So you can see like the person is coming to an emergency with a holding an hand on his chest, is not able to, that severe chest pain will be present. So what actually leads to that chest pain is, so the major villain in this disease is nothing but atherosclerosis. So what actually happens in this condition is, suppose imagine this is an coronary artery, right? We all know like fat foods are like very dangerous to the heart, and fat containing foods are very dangerous, because what happens is in the coronary artery there will be a deposition of fat. So this is the fat. There is an fat deposition where in the innermost layer of a blood vessel, that is tunica intima, and above the fat there is an one fibrous cap is present. Now I showed in the black is nothing but fat deposition, and this green is nothing but your fibrous cap. So this green is fibrous cap, this is fibrous cap. Suppose whenever there is a tear in this condition, so there is a tear in this condition, this is known as that diagram that I have represented is atherosclerotic plaque. Whenever there is a tear or cut in this fibrous cap or in this fat deposition, together known as atherosclerotic plaque, that is known as plaque fissure. So there is a tear, this is known as plaque fissure. Whenever there is a tear in this, that is known as a condition known as plaque fissure. So what actually happens after the tear is, whenever bleeding will occur, the body's own security mechanism, that is collagen, will come into the action. Whenever collagen will come into the action, collagen is like a magnet, it will attract the platelets. Whenever platelets will get attracted or collagen will get activated and platelets will get come into an action, so whole of this coronary artery will get blocked by this platelets, right? Here everything, these platelets will get clots will get activated over here, and it will get present and block the main coronary artery. So this is the reason how clot will get accumulated in the coronary artery. So this is about physiology behind this. So how that, so whenever there is a clot, there is no movement of the blood and the oxygen demand will get increases to the heart, so that's why the person will develop a chest pain, right? So this is about atherosclerosis. So what I want to do, so I want to remove this clot in this condition, no? So how you can see there is the presence of an clot or not is nothing but your coronary angiography. Coronary angiography is nothing but it shows the clot is present in the coronary artery or not. Suppose what do you mean by this balloon angioplasty is, I will explain detailedly in the upcoming slides also. So for the just time being, remember what actually happens in this balloon angioplasty is, I will put a guide wire and I will, this is the clot, I will put a guide wire over here and I will deploy a balloon, right? I will inflate the balloon. Whenever I will inflate the balloon, the clot will get destroyed, right? And the blood flow will become normal. This is about normal phenomenon. So this is about balloon angioplasty. So if you want to look at the clot is present or not, you want to go for coronary angiography, right? And this is about treatment. So we all know leading cause of death is MI. And what are all the, so if anybody asks what are all the blood vessels involved in atherosclerosis is, don't answer and come coronary artery. So which is the most common blood vessel which is involved in atherosclerosis is nothing but your abdominal aorta, right? So whenever the coronary clot, this clot, it will go to the abdominal aorta, that leads to abdominal aorta aneurysm. So this leads to spontaneous rupture. This leads to spontaneous rupture. And next, if the same clot, it goes to the coronary artery, then the person may develop angina. There are three varieties of an angina, that is stable angina, unstable angina, and prinzmental angina. So I am removing this prinzmental angina because I will explain detailedly over in the next sessions in the upcoming slides. So next is MI. So remember, whenever there is a blockage in the coronary artery, you should think about angina and MI. So how you can differentiate, I will teach you in the further aspects. So here, all these conditions, the patient will be having chest pain, right? The patient will be having chest pain. The chest pain on exertion or emotion is stable angina, and chest pain at rest is nothing but MI or unstable angina. So this is the differentiating factor. And this coronary, this atherosclerosis, it may get involved your popliteal artery also. Whenever the coronary artery, it will block the popliteal artery, that leads to claudication. And next, it may involve brain, that is circle of villi, right? So whenever the same clot, it from the heart, it will migrate into the brain, so that leads to stroke like a manifestations, right? And what are all the causes for this atherosclerosis? The major villain in this disease is atherosclerosis. One is your diabetes, and the person is obese, that is obesity, and hypertension, and next is smoking, right? So these are all the causes or which will increase the speed up of an atherosclerosis, right? So if anybody asks, silent MI is seen in which condition? Is silent MI is seen in diabetes mellitus. And sudden death in diabetes mellitus is mainly not to an glucose levels or nothing. So it is mainly due to the MI, right? So what is the sudden death? So what are the causes for sudden death in an MI? So how death occurs? Why death occurs in an MI is due to arrhythmias. Arrhythmias are common in MI. So what kind of an arrhythmia is common? Such as VFib, ventricular fibrillation, or it may be an pulseless ventricular tachycardia. These are all the arrhythmias that occur in an MI. So what are all the markers of early identification of atherosclerosis? If you look into this, what you mean by the markers is, suppose imagine a young guy who is like 30 to 35 years, and his father and his grandfather has died due to this heart attack, and he came to your clinic and he is asking like, how much chances I may be having the atherosclerosis or heart attack in this. So you will be prescribing some test that is known as high sensitivity CRP levels, right? If this test, it is greater than 10 IU, then he may be a risk of developing the heart attack, right? So this is about early identification of this atherosclerosis. Which test is done? High sensitivity CRP. Like suppose if grandfather has an heart attack, and then now this guy is perfectly fine and he wants to know in the future if I may get an heart attack or like MI or my coronary artery stenosis, then you are going to do this test, that is high sensitivity CRP, right? And next you will going to see the total cholesterol and by HDL, right? And your value is greater than 3.5 to 5.5, then he may develop this disease. And next is homocysteine levels. If the homocysteine levels will get increased, the person may get development of an atherosclerosis. So for the treatment of an homocystinemia, we will be using this B6, vitamin B6, B9 and B12, right? And remember, the cardiologist will never prescribe vitamin E. Vitamin E is contraindicated in cardiovascular diseases because it will worsen the condition. Remember, vitamin E is contraindicated over here, and you will find that HDL is a very good level cholesterol, and this is a less in quantity in this condition, okay? And these are all the markers for early identification of atherosclerosis. And next is radiological findings. You can see like what are all the imaging modalities. You will see like, look at the diagram over here. I have established, like I told you in earlier also, this is a coronary angiography. Coronary, sorry, this is coronary angiography. So this is an invasive procedure. So why this is done? This is done because I'm injecting a dye into the coronary artery so that I come to localize where the clot is present. So it is a gold standard method. Coronary angiography is the gold standard one. So why I am doing this test is to know the clot, where the clot is present, okay, and it gives the details about how much percentage of your coronary artery is blocked, percentage of blockage, right? And this is an invasive procedure. And next, if the patient want to go for a non-invasive procedure, then which test? Coronary CT you are going to do. This is a non-invasive procedure. Coronary CT angiography. This is a non-invasive. But in India, most of the test is done in this coronary angiography. This is a best test and it is a gold standard test, right? So what actually this coronary CT angiography, it also teaches about blockage and it also tells about calcification. Okay, these are all the imaging tests which are going to do in the, there is a clot in the coronary artery. Okay, and this is all about angiography and atherosclerosis. So now let's move to our topic of discussion, that is angina. So if you look at this angina, chronic stable angina, so nowadays we will be seeing the questions of in an integrated fashion, like in a case scenario based. Suppose imagine a 60-year man, right? He is having hypertension and he is smoking a cigarette every day. So I told you, like if the person is having hypertension and is having a smoking, these are all the triggers of an atherosclerosis, and the patient has developed difficulty in breathing, and the patient has severe chest pain. So which I showed you on the diagram, like patient is having, is holding his chest, hand on his chest, and that sign is known as Levin sign, right? 60 years man, hypertension and smoking, and he is having this chest pain. He is having this chest pain on exertion or emotion, right? Or after having the food, right? He is having this chest pain, and the person is completely fine when he is not doing any physical activity. He is at rest, right? So this is like completely totally different. A person has went to a parking lot and he sat in the floor itself to take the car, and he sat in the floor itself, and he went, and the security he took to the hospital. After coming to the hospital, the doctor has advised the ECG, and the ECG is completely normal. When after coming to the hospital, and his son is from medical background, and he's like completely is telling that, you are telling that my father is having a narrowing in the coronary artery. So how it's possible? Because whenever this chest pain or symptoms will get accumulated in this person, the ECG will show ST depression, right? ST depression is seen in chronic stable angina. After, when these symptoms will become disappear, when the person will completely, when he is at rest, the symptoms will get disappear. At that time ECG is normal and everybody is surprised. So what actually happens in this condition is, imagine this is a coronary artery, normal coronary artery, and what happens in this condition is, right, there is a narrowing of the coronary artery. So I am not telling any clot is present. If the clot is present, then you may go to the MI. But here there is a narrowing of the coronary artery. Even there is a narrowing of a coronary artery, the person is not dying, because there will be a bulging action of the coronary artery, right? The coronary arteries will bulge over here. So that's why some amount of an oxygen can pass or blood can pass through the coronary artery, the heart. Okay, this is about chronic stable angina. In the chronic stable angina, what you are going to remember is like chest pain on, if the examiner, if they mention chest pain on exertion or emotion or after having the food, that is postprandial, right? So these are all the key features you want to keep in your mind. And what about ST segment? When the symptoms have appeared, such as chest pain is appear, you are going to do ST segment is depressed, and when he is completely normal, the ST segment is completely normal and ECG is absolutely normal. Okay, so this is about chronic stable angina. So how you can do? So what are all the tests you are going to do over here? This is about treadmill test, TMT, right? You are going to do the treadmill test, right? And next, if the person, imagine if the person is too fat and if you are cannot able to do this treadmill test, so what test you are going to do is stress echocardiography. So what you will do is like you will put this IV dobutamine. You give this IV dobutamine. The person beta 1 receptors will get stimulated and heart rate will get increases, right? So suppose like imagine there is a very fat guy and who cannot do this TMT test, treadmill test, then you are going to do this like stress echocardiography, right? So this is about how we are going to do the treadmill test. So now let's move on to the treatment of a chronic stable angina. So what are all the treatments? Yes, beta blockers. So that to which beta blocker you are going to use? Metoprolol. So what is the function of using beta blockers in this is like it decreases oxygen demand and it also reduces, very important, maximum mortality. Beta blockers have shown that they will reduce the maximum mortality in this disease. And next is like aspirin. Low dose aspirin is given in this patient. So aspirin is an antiplatelet drug. So we know like in the coronary artery, we'll be discussing in further also, like there is a blockage due to these platelets. Antiplatelet drug. So how much your dosage you are giving? 75 mg. And next is like whenever the person is having the chest pain, you are going to advise the sublingual nitroglycerin tablets. Nitroglycerin. And if the tablet is not available, you can give this in a buccal spray also. So remember, this is used in if the patient is having sudden chest pain. So what is going to use? Sublingual nitroglycerin. So this is used in acute chest pain, and you are going to use this isosorbide mononitrate. So this is then long acting. So I told you know, like after having the food, the person is having the chest pain. So like which tablet you are going to prescribe? Isosorbide mononitrate. Why? Because this is then long acting. Right? So this is about treatment aspect over here, and finally the ultimate treatment is revascularization surgery. So revascularization surgery is nothing but your angioplasty, which I have explained earlier. Plasty, or it is also called a percutaneous intervention, and I am going to do this bypass surgery. Sorry, and I am going to do bypass surgery. In bypass surgery, which is used? If they ask, you are going to tell internal mammary artery is used. Okay, this is most commonly preferred, and you can use this radial artery also, and if you can use great saphenous vein. So best is no doubt internal memory artery, but due to lack of facilities and all, we won't be doing that. And most commonly which they are giving, which they are used in hospital setup is GSV, great saphenous vein. Okay, and this is about coronary artery bypass grafting, CABG. So where CABG is done? So CABG is done whether there is two blood vessels are involved, or like if only this major blood vessels such as left anterior descending artery is the major blood supply to the heart. When this will get blocked, I am going to do this coronary artery bypass grafting, right? And in case of a double vessel disease, single vessel disease are nothing but only like circumflex or left circumflex artery is involved. So I will be teaching in a next slides. So for time being, remember CABG mainly it is done if there is a blockage in this left anterior descending artery, which is the main coronary artery that supply the blood supply to the heart, right? In the MI, this is the artery which will get involved over here, left anterior descending artery. Okay, and this is about CABG. And next we move to the unstable angina or accelerating angina. So what your key feature you are going to see here is chest pain at rest. So there we have seen in the stable angina chest pain at exertion or emotion. Here you are going to see the chest pain at rest. Okay. So what actually happens here is atherombolism. So what do you mean by this? What actually happens in this unstable angina is, suppose imagine this is a coronary artery, right? I showed the narrowing also, and here there is a platelets, and this the platelets they have break down into small pieces, and they will get migrated into smaller blood vessels. These are not small blood vessels, right? These are also called as perforations, right? So here also the platelets got migrated over here. So these are all small blood vessels, and the platelets got migrated into small blood vessels, right? So remember, the treatment aspect for non-ST elevation MI and unstable angina both are same in all these conditions, right? Thrombolysis is contraindicated. Why thrombolysis is contraindicated? Because if I give this thrombolytic to this patient, it will worsen the condition. Already the clots are present over in this. If I give this thrombolysis, if I give this thrombolytic drug, again it will break this small clots, and again it will occlude it. So that's why thrombolysis is contraindicated in non-ST elevation MI and unstable angina. So remember, the chest pain at rest, you are going to think about MI or unstable angina. So how you can differentiate whether it is an MI or an unstable angina is by through the cardiac biomarkers. Cardiac biomarkers are elevated in MI. Here it is absolutely normal. Okay. So then what about ECG findings over here? ECG findings here also same thing. ECG ST segment is depressed and T wave inversion. T wave inversion. Right. So this is about unstable angina. So what is the treatment? Same, best. This is the mnemonic for angina and MI. Here, what is this? B stands for beta blocker. So, sorry, I will write it in a new page. Okay. Okay, let me teach you the treatment aspect of unstable angina and non-ST elevation. Both are same. I told you, as soon as the patient will come to your OPD, you are going to give this heparin to this patient, which is enoxaparin. So the treatment aspect include best, moon. So I have highlighted T because like you are not going to give thrombolytic to the patient, it will worsen the condition. Okay. What is this? B stands for beta blocker, and E stands for enoxaparin, and S stands for statins. So why these statins are given? Statins are given to stabilize this atherosclerotic plaque, right? So if I give the statins, the tear will, I taught you that plaque fissure, right? That will not get happen over in this condition. And T is nothing but thrombolysis is contraindicated in this patient. So that's why I have written in the red. And M stands for morphine. Morphine, how it acts? Like it will decreases the oxygen consumption, right? The oxygen demand is more and supply is also less. So that's why it will put a break on that. And next is MOAN. O stands for oxygen, A stands for aspirin, and N stands for nitrates. These are all the treatment aspects of unstable angina. Treatment of both unstable angina and non-ST elevation are same. And next we move to one more aspect, that is Prinzmental angina. So what do you mean by this Prinzmental angina? Is nothing but this is like there is no blockage, nothing and all over here. There is a spasm in the coronary artery, okay, and it is commonly seen in the females. In all the condition above the condition I told, like all the above anginas are common in the males, but this is the key feature in the exam hall. Here it is common in the females, right? The spasm in the coronary artery that leads to vasoconstriction, okay. So this is an coronary artery, and here if it's normal one, and in this condition you will see there is a spasm, right? Spasm in the coronary artery. So this is, and one more important point is ECGs. So this is the only angina. This is the only angina. I repeat, this is the only angina. You are going to see this ST segment elevation. Okay, ST segment got elevated in only this angina, that is Prinzmental angina. It is also known as variant angina. So it basically occurs why there is a spasm in the coronary artery, right? Not any blockage or any narrowing or all. Spasm in the coronary artery. So how do you treat? Treatment of this aspect is calcium channel blockers. Okay, calcium channel blockers such as amlodipine or the drugs which are given in this condition. So this is about angina. So let me glance you, like let me teach you about all the angina in a very short duration. Okay, so this will be helpful for at your revision time. Okay, angina is very important. Chest pain, and now we have three types of an angina. One is stable angina, unstable angina, and next one is Prinzmental angina. So here, how you can, in the examiner how they will mention chest pain. Chest pain is common in everything. Chest pain on exertion or emotion. In this both the condition you will find chest pain at rest. Here also in Prinzmental angina, chest pain at rest. Okay, and male. Here also male patient, and here it is female patient. So what you are gonna, ECG findings are very important. ST segment depression. Here also ST segment depression, only angina in which there is an ST segment got elevated. Okay, and next coming to treatment, beta blockers. Here also same, best moon, beta blocker. Here calcium channel blockers. These are all about which I have explained in a single slide. Okay, and next this is about angina, and next we move to the one of the most important topic, that is MI or myocardial infraction, right? So look at the here also same, the chest pain is radiating to the arm, jaw and all. So let me discuss about what actually happens in myocardial infraction is, suppose imagine this is the coronary artery, and here there is a development of clot, right? Here there is a development of a clot. So coronary artery and clot. If the clot that will completely occlude the coronary artery, that is known as ST elevation MI, or it is also known as full thickness. Remember, I am going to use the word, one of the most important topic. If the clot is composed of thrombus, in ST elevation MI, the clot is mainly of thrombus, right? And in non-ST elevation MI, the clot is mainly, it is composed of platelets. I taught you know in unstable angina also the platelets are present, but it is not completely occluding the coronary artery. It is involving the chotu blood vessels, that is like small blood vessels, so that perforators, right? So in this MI, the non-ST elevation MI, the clot is made up of platelets, not thrombus. This is then platelet is present over here. So this leads to the platelet retention. Platelet rich clot is present over here. So that's why I'm using, like I told you in earlier also, there is no role of giving the thrombolysis. Like thrombolytic is nothing but clot is not rich in the thrombus. Here the clot is rich in antiplatelet drugs, right? So that's why antiplatelets I'm going to give in this patient. That's why fibrinolysis, sorry, fibrinolytics are contraindicated, or thrombolytics are contraindicated over here. Or contraindicated in this condition. Okay, and this is about ST elevation MI and non-ST elevation MI. Very, very important. Here also the patient will be complaining at chest pain at rest. So how this chest pain is like in MI or in the angina and all, if you take the chest pain after taking this sublingual nitroglycerin or whatever tablets, you will get relief from that. Here after taking that also you won't get relief in this condition. So the chest pain is more than 20 minutes, right? So this is about ST elevation MI. The in major thing which you are going to see is like in ST elevation MI, thrombus is present or thrombo. So that's why here thrombolytics can be given in ST elevation MI, and in non-ST elevation MI, thrombolysis is contraindicated. Why? The platelets are present more in this condition. So that's why it is a platelet rich clot. So not, there is no role of giving this thrombolytics or fibrinolytics such as streptokinase, alteplase, tenecteplase. They are contraindicated in non-ST elevation MI and unstable angina. Okay. So now let's move on to one of the most important where the examiner will focus is ECG findings. So ECG findings, which is the first you are going to see is like hyper acute T wave. So don't mark and come tall tented T wave. I will teach you now. Tall tented T wave is seen in hyperkalemia, not in MI. Hyperacute T wave is seen in MI. So if you look at this T wave, vertical height, what do you mean by this hyperacute T wave is, if you look this T wave vertical height, it is less than 5 mm in limb leads. And when you come to this chest leads, it is less than 10 mm in chest leads. Okay. So I will draw for you. So this is hyperacute T wave. This is hyperacute T wave. And now I will draw tall tented T wave. Tented T wave. So what is the difference between hyperacute and tall tented T wave is, so look at the diagram carefully over here. It is like pointed. Here pointed. Here it is not pointed. It is look like somewhat broad over here. I've drawn broadly, and here it is a pointed is present over here. This is the difference, and this is the how you can differentiate whether it is an MI or like hyperacute T wave or tall tented T wave. Okay. So this is about, don't forget, don't, most of the students they will answer this tall tented T waves. No, it is an absolutely wrong, and the correct option over is hyperacute T wave is seen. Okay. And next, like what next ECG finding is T wave inversion. T wave inversion. Okay. And next is like ST segment, you may get elevated. So I will draw it over here. Sorry. So you may find, so this is an T wave will get inverted. This is T wave inversion, and here there is an ST segment elevation is present over here. ST segment elevation. Okay. So this is about ST segment elevation. How you can see the convexity over here. Convexity is seen in ST segment elevated condition. So this sign is known as Pardee sign. So Pardee sign is nothing but like ST segment elevation, or it is also convexity, and it is also known as a tombstone appearance. Okay, this is about ST segment elevation or convexity, and these are all the ECG findings you are going to see, and this is the most important slide over here. And now let's discuss about types of an MI. Like, let me hand draw for you. So what are all the blood vessels that are going to involve in this condition and all. So I will teach you about what are all the blood vessels which are going to block in this coronary artery. So everybody will be telling anterior wall MI, inferior wall MI, lateral wall MI, and septal MI. So let's discuss about, so what are all the ECG leads you want to, this is very important. So this is the septal one, this is the left ventricle, and this is the right ventricle. Okay, and I will use different colors so that you won't forget. And this is the main coronary artery, that is left anterior descending artery, which supply the blood supply to the left part of the heart. This is left anterior descending artery, and its sub branches is circumflex artery, and this is left circumflex artery, and this is septal one, and the one which I mentioned is nothing but right side. And this is your right coronary artery. So imagine, so if you want to know the function of this left anterior descending artery, which ECG leads you are going to do, which chest we are going to use is like this lead number V2, V3, V4. They are like CCTV cameras. They are like CCTV cameras, and they will only study this left anterior descending artery. So that's why, which is the most common artery that is involved in an MI is left anterior descending artery, and where it is present. So this is the diagram which I have shown you is the 2D representation of the heart, right? So this V2, V3, V4, it completely, it only studies this left anterior descending artery. Suppose if there is a blockage in this left anterior descending artery, here we will see the death of an muscles over here, right? So which leads are helpful to study the left anterior descending artery is nothing but anterior wall MI. This is the most common type of an MI. Whenever there is a blockage is present in the left anterior descending artery, which leads you are going to see V2, V3, V4. It is present in a CCTV camera. It will be studying the heart. So that's why it is an anterior wall MI. Suppose now I want to know this part. If the block occurs in this region, this is known as interventricular septum, IVS. So this is known as septal wall MI. So which lead is used? V1. So imagine this V2 is present over here also, right? So this, I want to study the septal wall MI. Which leads are helpful? V1 and V2. Okay. If I want to know this circumflex artery, it is present in the lateral sides. It is also present in the lateral side. So that's why this is known as lateral wall MI. Okay. So which leads are helpful? V5 to V6. Okay. And next, if I want to know the, suppose the clot, it all, not only it is present in the left anterior, most commonly it is present in the left anterior descending artery. So the clot, it may be present in this coronary artery, in the right side also. Over here also the clot may happen. If I want to know this clot in this right coronary artery, which leads I want us to is lead 2, lead 3 and AVF. So what it tells about inferior wall MI. Wall MI. Okay, this is very important and we can expect the questions from this blood supply and what are all the leads which, so I will write it in on one more new page. So okay, so let me, so if what lead V1 will tell, it is an septal wall MI. Okay, left anterior descending artery will get blocked, which leads V2, V3, V4. What it will tell, this is very important, this is most commonly you involved over here. And what you are going to do is like anterior wall MI. And next, if I go up, it is V5 to V6, which it, what it involves, lateral wall MI. V5 to V6, lateral wall MI. Okay. And next is like lead 2, lead 3 and AVF, right? It is like present at the down of the base of the heart, So it base is nothing but base is formed by the right ventricle. So that's why this is an inferiorly located. So this is about inferior wall MI. Okay, these are all about MI and what are all the leads you are going to see in this condition. So now let's go for the chest lead positioning. So, and one more thing is like V7 to V9, it tells about posterior wall MI. Okay, so these are all about lead placement. So now let's look at the where these leads will be placed. So V1, V2, V3, V4 until V9. So let me place first V3 because V3 is placed in between the V2 and V4. Okay, and V1 where it is placed, this is the only lead which I will place on right side and rest of the leads I will place on left side. Left side, left, and everything I will place on left side. Left side and left side. Okay, and next where you are going to put this V1 is right side, which fourth intercostal space. Here also V2 is also placed between fourth intercostal space, and when we come to V4 to V9, everything it is placed on fifth intercostal space. Fifth intercostal space. So very important lead placement. So where it is placed, V1 right side, fourth, this is the only lead which I am placing on the right side on fourth intercostal space, and parasternal line. Here also same, parasternal line. Okay, and next here mid clavicular line, and next is V4 is placed. So I taught you V2 parasternal line. V3 is very simple, it is placed between V2 and V4, and V4 is placed in the fifth intercostal space, mid clavicular line, and V6 is placed between V5 is placed in the anterior axillary line, and here V6 is placed between mid axillary line, and next V7 posterior axillary line, and V8 is placed in scapular line, and next it is V9 is placed in paravertebral line. So this is the lead placement you should know, and this should go in your last minute revision notes because questions may expect from these condition lead place. So not only for an examination of a view, in your general practice also you will be seeing this how to place the ECG leads and all, right? So this is about chest lead positioning. V1 is placed in the right side. Let's briefly study. First we will put the V3 because it is placed between the V2 and V4, and V1 where you are going to put right side, fourth intercostal space. This is the only lead you are going to put in the right, and next rest of the leads left, left, left. There is no confusion. And upper V1, V2 are you placed in the fourth intercostal space, and all these after V3 you are putting in the fifth intercostal space, right? And next is like upper two are placed in parasternal line, and V4 mid clavicular line. Remember the mnemonic V4 to V5, V6 like MAM, right? Mid clavicular line, anterior axillary line, mid axillary line, and next you is nothing but PSP is over here, and that is your posterior axillary line and scapular line and paravertebral line. These are all the lead placement V7, V8, V9 posterior wall MI, right? So I taught you about leads. This is very important. Please go through for this before going to the exam. And next is like cardiac biomarkers. I taught you like cardiac biomarkers are elevated in an MI. So what biomarkers they are gonna elevate over here is, so let's look at over here. So what are all the cardiac biomarkers? So when I was in student time, like I used to mark like a myoglobin. So nowadays myoglobin is, no, I'm not telling like myoglobin can mark, but there is an one biomarker, two biomarkers which rises earlier than myoglobin. So what are all these like? Ischemia modified albumin, right? Ischemia modified albumin, and next one is heart fatty acid binding protein. Okay, right? These are all the first which are earlier to rise than myoglobin. So if the examiner asks which is the first biomarker that is rise to an MI, if the option contain any of these, first is this, second one is this. So if the exam hall, if ischemic modified albumin is present, go with this. If this is not given, then if you have the option heart fatty acid binding protein, this you should mark. But anyhow, if you are appearing for an NCLEX like an UK or US based exams, this question may come. Like in not only in US, in these tests are not used, but I have taken it from American Heart Association guidelines. Like they are told like cardiac biomarkers which they are elevated here is like ischemic modified albumin is the first to rise. So please go through this. But anyhow, in general practice, we used to mark this troponin I. But troponin INT are very good test, and it will tell us it is very good test, and it will rise after 3 to 4 hours. First to rise is ischemic modified albumin, and if this is not there, then no doubt myoglobin. When I was in student time, we used to mark this, no, like myoglobin is the first to rise in MI, right? So in pathological aspect it is also true, but what is the disadvantage of myoglobin is like you give the DC shock, whenever the muscle will get damaged, myoglobin levels will also get elevated. No, that's why specificity is not that much good as compared to the troponin INT. And which is the most specific and sensitive test is most specific and sensitive test is troponin I and T. So how they are going to write is troponin I. So normally this troponin I value is less than 0.04 nanogram per DL. Okay, and if it get elevated, it will get elevated for 10 times in an MI and all. This is the most specific, and when it is going to rise between 3 to 4 hours, right? This myoglobin, it will rises like within less than 3 hours. So all these two tests, they will rise within the fraction of seconds or minutes. Okay, and next is one more test you are going to do is like CPK-MB, CPK-MB, and all these are all going to rise after the troponin I. This is also used for reinfraction. So these are all the cardiac biomarkers. So let me write you the order. Which is first to rise is that ischemia modified albumin. If this is not there, then you can go with heart fatty acid binding. If this is not there, go for myoglobin, and if this is not there, then you can go for your troponin levels. Okay, this is the order, very important table. Please go through this before going to the exam. Okay, then like investigations, ECG, you know, it may get ST segment elevated or ST segment depressed. Cardio biomarkers, they will be elevated, and angiography though I should do, because like I should know whether there is a present of an clot in the which anterior disc, so how much, to know the percentage of blockage, right? So this is about what are all the investigations you are going to do and all. So now let's move to the management of ST elevation MI. So we know what are all the management of ST elevation MI is. Treatment of choice is I should break the clot, right? So I should break the clot itself. So that is known as primary percutaneous intervention, PCI, right? So in most of the hospital, so suppose in MI or a chest pain, like, right, one of the famous cricketer Saurav Ganguly sir is doing workout in the gym, and he developed a chest pain, and his sir lives in a city, and he went to a very good hospital and he got treated over there. But in most of the hospitals, if you are in a rural areas, like, you don't be having this primary percutaneous intervention and all, right? So in India, like in US and all, like the ambulance used to reach within the 4 minutes. But in India, it is not, the roads are not good and the patient is coming late to the hospital. So PCI hospital, if the patient has came to the PCI hospital, like, you should send the patient to the cath lab immediately. Send to cath lab immediately. In the cath lab, what they will do is like, they will deploy the balloon and they will break the clot over here. So all this procedure should be done within less than 90 minutes, right? Within the 90 minutes, when the patient come to the FMC is nothing but first medical contact. Okay, and if the patient came to non-PCI hospital, this is the scenario number 2. You are working in a rural area where PCI facility is not available. So what you are going to do is like, you should tell the patient, like, please go to the nearest PCI hospital. So that is the first thing. So you should educate the patient that you should reach the PCI hospital within 120 minutes. The patient should reach the PCI hospital, right? If this is not present, like he is like in the very rural area, it will take more time to reach the Bangalore or in Hyderabad, many cities. So like, what you are going to do in such condition is like, you are going to give this start fibrinolytics. So when you are going to start the fibrinolytic is, the patient has came to your emergency department with a chest pain, and you have educated him that please go to the PCI hospital. He should reach the PCI hospital within the 2 hours. And he told that due to some strike or something is going on, so I cannot reach. And the patient will say that, sir, we have completely trust on you. So do these thrombolysis. Then you are going to start the thrombolytics or fibrinolytics within 30 minutes. So this is known as door to needle. So I will explain clearly in the upcoming slides also. So this is about non-PCI hospital. In non-PCI hospital also, first you should educate the patient that, like, please go to the PCI hospital within the less than 2 hours. And he tell that, no sir, like, you should take the proper consent, and you should explain in the local language also. And after taking the consent or all, like, even the patient attender won't obey, then you can start with the fibrinolytics, and you should be started within the 30 minutes. And this is known as door to needle time. Okay, so I will explain it clearly in the upcoming slides also. So next, after this is the first treatment you are going to do. And like, I want to control the symptoms, right? So like patient will be having extreme chest pain. So you same treatment, best moon. Okay. Here first I am going to give aspirin. Why? First I am going to give this aspirin because there is an acceleration, there is an, these platelets will be forming very fast, very fast in these conditions, no? So that's why this aspirin is an antiplatelet drug. Dual antiplatelet therapy, we call it as DAPT. Aspirin plus clopidogrel, will be combining aspirin with one more tablet, that is clopidogrel and all, right? So this is like antiplatelet drug. How much aspirin you are going to give is 325 mg, right? This is the dual antiplatelet therapy. And next you are going to give oxygen to the patient. And next is sublingual nitroglycerin. So nitroglycerin, like you should give to the patient. So how much you are going to give? 0.4 mg. Maximum how many doses I can give? 3 doses. What is the time gap that should be present? 5 minutes. Okay. And next you are going to give this nitrates. So one nursing intervention that I am going to teach you, if you are using the nitrate, is you should check the BP of the patient, because nitrates will cause the hypotension. So that's why nitrates are contraindicated in hypotension if the systolic blood pressure is less than 90. Okay. So that's why before giving the nitrates, you should check the BP of the patient. And next, morphine you are going to give because it is a painkiller. So morphine has not only painkiller, it has multiple actions. That is, morphine acts as a vagotonic action. So here, so look at, in this condition the heart is working more because there is a narrowing is present, so it should work more. So that's why if you heart rate is more in this patient. So if you give the morphine, it will decreases the heart rate also. Okay. And next is statins. So you should, so as a nursing officer, you should know the drug, and like in the one line you should know what is the action of the drug. So why morphine is given, it decreases the heart rate. Nitrates are where you should be given sublingual. So aspirin, why it is given here, there is an acceleration, it will be, antiplatelets are produced more in number, like platelets are like more, they will be advanced more. So that's why you should put a break on that. So that's why I am giving aspirin. So statins, why? This atherosclerotic plug, no, it will put the brake on this atherosclerosis. That's why you are going this statin. So why statin is used? To stabilize the atherosclerotic plaque. I told you, no, there is a tear in this atherosclerotic plaque. So whenever there is a tear, the thrombus will get migrated into other coronary arteries also. That's why I should put brake in this condition. So that's why that is done by the statin. Okay. And this is about treatment aspects. And now we know thrombolysis. I taught you thrombolysis drugs such as streptokinase, alteplase, tenecteplase, and all we are going to use in this condition. So these are all. So remember, thrombolysis, or what is the side effect of this drug, is bleeding. Okay, bleeding. And beta blockers are contraindicated in ABC, like acute congestive heart failure, in bradycardia, and in COPD, and in asthma, right? So please remember, beta blockers are contraindicated in ABC. That is like acute congestive heart failure. I am not using the word chronic. I will be, in my sessions I have covered this heart failure also. Like acute heart failure, beta blockers are contraindicated in bradycardia and in like COPD and in asthma. Okay. And these are all about management. And next we move to the non-ST elevation MI. Here the chest pain is radiating to the jaw. And next, arm and shoulders. So I thought you what is the treatment aspect of everything, like in non-ST elevation also same. Here platelets are present, so I should give this IV drug to this patient, right? So this is very important. Please go through this. And treatment aspect is same for everything. Best moon is the mnemonic which I have covered. Beta blockers, enoxaparin. Here I want to give this IV antiplatelet to this drug, like. So very very important, don't forget this thrombolysis is contraindicated in non-ST elevation MI, unstable angina. Okay, so please go through this. Like non-ST elevation is also same like chest pain at rest, chest pain at rest, and it is radiating to the arm, jaw, and all, right? And how you will differentiate whether ST elevation MI or non-ST elevation? By through ECG, you know, if the ST segment is got elevated, that is ST elevation. If it is not elevated, that is non-ST elevation MI. Okay, and next is like treatment. Here, best moon, same which I have explained earlier, beta blockers, enoxaparin, statins, and here T is not for thrombolysis, so that's why I have mentioned T. So one more T I am going to mark over here is nothing but tirofiban. So this is an IV antiplatelet drug, so I can give this IV antiplatelet drug, right? So that's why I have written in caps so that you won't get forgot. IV tirofiban is given in this condition. Okay, so next we move to the complications of MI. Complication of an MI you can remember by through the mnemonic A, B, C, D. A stands for arrhythmias. So what kind of an arrhythmia? That is ventricular fibrillation and pulseless ventricular tachycardia. So if they ask you like sudden cardiac death is nothing but time which is less than 1 hour, right? If the death occurs within 1 hour, so I will teach you in the later aspects. And B stands for bradyarrhythmias. So one of the most common bradyarrhythmia, that is complication of an MI, is Morbid's 2 heart block. I have covered in ECG session about Morbid's 2 heart block. And C stands for cardiogenic shock. This occurs within 24 hours. The mortality, death of the, so MI patient has admitted in the hospital, within 24 hours he got expired. So what is the reason? Cardiogenic shock. And D stands for Dressler syndrome, right? So this is about complications of an MI, and this is about MI complications. So now let's teach me about pharmacology. So this is an integrated session, so I have been explained physio aspects and anatomical aspects and pharmacological aspects and nursing interventions, so what you're going to do and all. And next is like pharmacology. So this is very important. MI, it is also known as acute coronary syndrome. So I am explaining here itself, acute coronary syndrome is nothing but chest pain at rest. I told you chest pain at rest is like 3 conditions. One is STEMI, ST elevation MI, and one more thing is non-ST elevation MI, and next one is unstable angina. Okay, so what actually happens here is, this is the heart. Here there is a complete blockage, so that's why it is in full thickness. Here partially blocked, that is partial thickness, and here there is no blockade, and here only it is an ischemia, right? Less blood supply. And what about ST segment? In STEMI, ST segment will get elevated, and here depress and depress. So how do you differentiate also we know. So let me teach you. Initially I will be doing symptomatic treatment, right? I should be controlling this pain and all. MOAN, morphine, oxygen, aspirin and nitrates. Morphine, oxygen, aspirin and nitrates, right? So if, so this is like for mnemonic I taught you MON. So which is the first drug that you are gonna give here is aspirin plus oxygen. Okay, and next you give nitroglycerin, and next Morphine. Remember, first you are going to give is aspirin. Why? In all the conditions you are giving this aspirin. Why? There is a chances of acceleration of these platelets will become fast growing, right? So that's why I should put break on that. So aspirin, how it acts? It will like tax A2, thromboxane A2 inhibitor. Okay, morphine, and next is like statins, atorvastatin and all. So these are all like initially steps for MI. So what is the definitive treatment? So definitive treatment is of, it is also known as reperfusion therapy. It should be done within less than 12 hours. So I will teach you definitive treatment is like two parts, that is thrombolytics and percutaneous intervention. So what are all the thrombolytic drugs that we are going to use? Yes, tell me. Alteplase, tenecteplase and streptokinase, right? So what is the advantage? This is an faster, and what is the disadvantage? It is an bleeding will occur over here, and percutaneous intervention is completely safe, right? So now when we come to this unstable angina, ST elevation MI and sorry, non-ST elevation MI and ST elevation MI. Okay, so sorry, so I'll mark a line over here. So this side is nothing but thrombolytics and this side is percutaneous intervention. So here for unstable angina, I can do percutaneous intervention. Yes. For non-ST elevation, yes. For stemito, yes. And like what about thrombolytics? I can be given in unstable angina? No. In non-ST elevation MI? No. In ST elevation MI? Yes. I can give the thrombolytics. So like thrombolytics, door to needle is nothing but patient coming to the emergency or at your door, right? You are doing the thrombolytics, that is known as door to needle time. So how much it should be? You should done within less than 30 minutes. And what about this percutaneous intervention is known as door to balloon, because I will deploy a balloon and I will break the clot. So that's why that is known as door to balloon. So you are going to do within 90 minutes. Okay, these are all about treatment aspect of an MI, disease aspects, how the disease will get. So main thing, acute coronary syndrome is like you should think about three aspects, that is STEMI, non-ST elevation MI and unstable angina. So let me briefly wind up the session with revision of all the anginas. So we have resolved, and now how to differentiate between MI and angina. By ECG though? No, I cannot, because ECG like ST elevation depression I can see in this by through this cardiac biomarkers, cardiac markers are elevated in MI or and it is a normal in angina. Okay, and one more about treatment aspects, like where you should use the thrombolytics and where you should not use the thrombolytics, that I have explained in earlier also. And if there are sudden cardiac death in an individual is nothing but death within 1 hour. Okay, so please go through this carefully. Door to balloon, door to needle and all, like definitive treatment is like percutaneous intervention, pharmacology, complications and STEMI. So very important is like thrombolysis is where it is contraindicated. In a hemorrhagic stroke or bleeding, whenever bleeding is present, you should not use in an hypertensive patient or hypertension, like if the BP is greater than 180, there will be chances of an intracranial hemorrhages and all, right? So in all these conditions, you are not going to use these thrombolytics. So lead placement, blood this supply, and which are going to block MI, and I have explained everything about angina. So this is like must know topic, not only for your exam, in day-to-day practice you will be seeing this lot of the patients in your OPD and in your general practice also. So this is all about today's session, and thank you for hearing guys, and keep studying.